Okay, welcome everyone. My name is Tristan Claridge and I'm the convener of this webinar series for the International Social Capital Association. The association's mission is to advance the research and application of the social capital concept. And if you're interested in membership, the association is welcoming new members. In this session, we welcome Dr. Michael Lebenbaum from the Canadian Cancer Society for a presentation about health and social capital, a series of empirical studies on the causal effects of health on social capital. Michael Lebenbaum is the Senior Manager, Health Economics and Outdoor Research for the Canadian Cancer Society. He completed an MSc in Epidemiology from Western University, a PhD in Health Economics from the University of Toronto, and recently completed a postdoctoral fellowship at the University of Wisconsin-Madison. He has also worked as an epidemiologist at the Public Health Ontario and ICES. His research interests include applying econometric methods to examining the determinants of social capital and social impacts of illness, and conducting studies estimating the cost effectiveness of public policies. We're delighted you've agreed to give this webinar, Michael. Over to you for the presentation.
Thank you very much for the introduction, Tristan. I'll be presenting the results of a series of studies that I conducted in collaboration with Claire de Oliveira, Franz Gagnon, and Audrey Laporte, who are my PhD dissertation committee members. So social capital can mean many different things, but generally within the economics literature, it typically refers to resources that are derived from social networks that are and these social networks are thought to exist due to prior investments in these relationships. Investments typically refers to activities that will help build your social network, like organizational activity and various forms of social participation, like volunteering and church attendance. And there's often reference to the stock of social capital, which is the overall level of social capital, or which typically reflects accumulated resources, such as the number of friends who are willing to help you out with a favor, or available social support. I also draw on concepts from sociology, Granovetter's concept of strong and weak ties. Strong ties typically referring to, I think, family and friends, and weak ties more like acquaintances and potentially coworkers and neighbors. There's a large body of research that has examined the effects of social capital on health, with social capital defined in many different ways, as well as health being defined in many different ways. And a lot of that research is focused on mental health, where I think there's generally a research showing that there's a positive effect. Economic models highlight that health is an important input directly into social capital. It's used to build social capital, and it could affect the efficiency production, so how much people get out of a specific investment in social capital, and people may use up their social capital to generate health. So these are some ideas that are common across, or at least included in some of these economic models. Despite the increasing prominence of these economic models, there's been very few studies that have examined the effects of health on social capital. It's in part because I think there's a number of significant challenges in estimating the effect of health on social capital, including this reciprocal relationship, as well as potential measurement error. Studies have shown that if you, for example, experimentally induce depressive symptoms in individuals, it does affect their perceptions of their social capital. So short-term, like anxiety and depressive symptoms could negatively affect people's levels of perceived social capital without actually affecting their levels of social capital. studies examining the effects of health on social capital have been conducted among adults. There is a number of studies that have used panel methods like cross-like panel methods or instrumental variable methods to try to account for simultaneity. But these studies have generally focused on short-term symptom scales, like like within the last 7 to 28 days, and they're generally focused on social participation. Studies examining longer term measures of mental health or levels of social capital stock are lacking. So the first study I'll present looks at adult mental health and the stock of weak tie social capital. Another approach to addressing simultaneity and measurement areas to examine health in childhood, not during the same period with which social capital is measured. And there is a lot of economics research that has used this approach to look at health and other social outcomes like human capital and labor market outcomes and adult health. However, there is, to my words, no studies prior to my study that examined adult social capital within the economics literature. And there was a few studies that outside the economics literature that have examined this kind of relationship, but they largely focused on depression and volunteering or social support. Other measures of social capital weren't examined, and there was quite limited control for confounding, especially familial confounding, which has been shown to be very important in these other economic studies, and no applications of sibling fixed effects, which is when you examine associations within sibling pairs, and that's the gold standard for methodology when it comes to studying the effects of child health on later life outcomes in the economics literature. So the second study looks at child health and adult social capital. And then volunteerism is an important investment particularly into weaker ties related social capital. And although there were many studies early on in the pandemic that looked at the effects of lockdowns on mental health, some that looked at social isolation, and many that looked at employment related outcomes, there was almost no research examining volunteerism. With only one study showing like increased Wikipedia contributions and another study examining the dynamics of volunteering in the UK. And COVID-19 had, especially early on, had many complex effects given, physical distancing policies, health risks, unemployment shocks, and no studies examined the demand for volunteers by nonprofits or interest of volunteer, and definitely not across different types of causes. So the third study I'll present looks at the COVID-19 pandemic, lockdowns, and volunteerism. So the first study focused adult mental health and adult social capital. The research questions were, what is the effect of adult mental health on individual level adult social capital? And does this differ by type of mental health measure? We used nationally representative Canadian survey data that was a mental health specific survey that had rich measurement of mental health. It had some variables that could act as instrumental variable analyses, and we had shorter and longer term measures of mental health, as well as the stock of social capital. And so using these two data sets, multiple IVs, and numerous robustness checks, we found significant effects of short and long-term measures of mental health on the stock of weak ties. So these two data sets were the 2012 Canadian Community Mental Health Survey, as the mental health specific edition. And for some sensitivity analyses, we also use the 2002 version of the same survey, where they have largely the same design. Canadians age 15 plus from the provinces, excluding the territories. Like other Canadian nationally representative surveys, it typically has certain exclusions, like those who live in institutions, individuals living on indigenous reserves, and homeless individuals. There's about 25,000 individuals initially, and after sample restrictions and missing data, there's about 22,000 individuals for sense of belonging analyses and about 11,000 for workplace social support analyses, given not everyone was in the workforce. So the mental health variables were the Kessler-6 psychological distress scale, which measures anxiety and depressive symptoms. Self-rated mental health is typically measured which ranges from excellent to poor, and then the count of mental health conditions. And this was assessed with the WHO's CIDI 3.0, which is like a structured diagnostic scale that attempts to recreate the diagnoses that a psychiatrist would provide. And they assessed depression, bipolar, generalized anxiety disorder, as well as substance abuse and dependence conditions for alcohol, marijuana, and then all other substances combined. And then weak ties social capital was assessed by sense of belonging to a local community. And this, at least within the Canadian setting, has been shown to be very strongly correlated with whether you know neighbors in your community, in your neighborhood, and whether those neighbors will are willing to give you a favor. It has a weaker association with friendship and almost no association with the number of family members in a city, for example. So it's largely a measure of neighborhood social capital. And then we also use a measure of social capital related to workplace social support. And it was important that these forms because of our analytic strategy, it was important that these forms of social capital were as unrelated to family members as possible. And the reason for this is the main estimation strategy is using instrumental variable analyses, and we use family members' mental health as the instrument, which is commonly used as an instrument within the labor economics literature to estimate the effects of mental health on labor market outcomes. And the result that your family members' mental health shouldn't have a direct effect on the outcome. So that was the reason why we only looked at non-family member related social capital. And the reason for this is, for these instruments, is we expected there to be based on prior studies, a very strong first stage association between the IVs and the endogenous variable, i.e. your own mental health, which is largely due to genetics, and it should pass the exclusion restriction criteria. And we ran over identification tests, which can shed some light on the validity of the exclusion restriction. And we did a number of robustness checks, looking at different subsamples, IV sensitivity analyses, and alternative IVs. And more or less, the results were very similar. This just gives you a sense of the distribution of variables. Most people had one or two past year mental health conditions. Most people reported excellent or very good mental health. About 9% had fair or poor mental health. And most people were in the lowest category of psychological distress. Although for the analyses, case 6 was modeled continuously. So you can see here, there's in the main IV specification, there's a pretty strong effect of mental health on sense of belonging. And whether it's measured as past year mental health conditions, which is a more longer term measure of mental health, self-rated mental health, which reflects shorter and longer term mental health, and case 6, which is only short-term mental health. And in various sensitivity analyses, where we expect the IV to have less an potential effect on the outcome, such as like individuals who live alone or younger individuals, we find similar conclusions. If we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, which may potentially have an effect, we find very similar results. And if we exclude people who have family members with more severe mental health conditions, And also, when we did an alternative IV, the number of mental health conditions with onset in childhood or adolescence. And in this analysis is in a separate data set, the earlier edition of the survey, we find qualitatively very similar and almost, for example, for the K6, the exact same point estimate. So I think this provides fairly, and sorry, also because the S statistics are all quite high, well above 10, and the override identification tests are well above 0.05, I think it provides fairly strong evidence that the IV is most likely valid. And then we find very similar results for workplace social support with quite large negative effects of adult mental health on workplace social support. And similarly, very similar qualitative conclusions and mostly similar point estimates across a wide range of subsample restrictions and analysis estimation methods. So all measures of mental health, both short and longer term, had significant negative effects on both measures of weak to high social capital across multiple robustness checks. All the results had very similar qualitative conclusions and mostly similar point estimates. It's important to remember some of the limitations, this being cross-sectional data, although the IV helps deal with the simultaneity. Some of the measures were retrospective, but others are not. Spousal and children mental health was included in the IV, but through some of the sample restrictions, as well as using an alternative IV, would also address this limitation. But IV also requires a lot of assumptions, and theoretically, it's impossible to prove those assumptions. So there's still potential violations. But I think overall, it provides fairly good evidence to support the need for greater access to evidence-based mental health interventions, as well as I think research into social capital interventions. Given my read of that literature is that generally they to date have found fairly low the evidence isn't great in terms of improving social capital among people who have mental health conditions. So it probably suggests we need to do more research into other interventions, maybe social prescribing, and specifically test those interventions among people who have significant mental health challenges. The second study was focused on child health. The research questions were about the effect of child and adolescent mental and physical health on adult social capital, whether this differed by the condition. And we used the ad health cohort from the States, and we more comprehensively measured child health and social capital, as well as apply sibling fixed effects for the first time. And we do find significant attenuation of some associations due to application of sibling fixed effects, but we do find that greater self-rated health is associated with several measures of social capital, and that early life mental health conditions have large negative effects on social isolation later in life. We used the National Longitudinal Study of Adolescent to Adult Health. It was first conducted in 1994-5 when they recruited about 21,000 adolescents, grades 7 to 12, into a longitudinal study. Parental data was available for about 85% of them. And then there are adults in waves 3 through 5 when they're ages 18 to 43. And then there's different definitions of adulthood, but given the nature of the survey, as well as DSM and some other criteria often use 18 as the cut point, we used 18 as the definition of childhood. We looked at a number of social capital measures, some that are more investments like volunteering, religious service attendance, team sports, and a number of stock-based measures such as number of friends, social support, and social isolation. We looked at overall health as reflected by self-rated health, depression, conduct disorder, ADHD, and anxiety and substance dependence. Some of these were only based on symptom-based variables, such as conduct disorder. Some of them are based on both symptom-based measure, like depression, and also has a corresponding clinician diagnosed variable. Um, uh, I'm not going to present all the different sensitivity analyses, but in the paper we looked at these variables together as well as separate, as well as those that are based on retrospective versus recall, or versus those that were measured at wave one. And the conclusions across these different sensitivity analyses were largely the same. And then we also looked at physical health conditions, including some of the most common childhood conditions like asthma, migraines. Um, so we more extensively controlled for confounding by including a number of individual, family, and geographic variables, such as demographic characteristics, intelligence, parental treatment, such as parental investments, as well as child abuse, parental socioeconomic status, and their social capital investments, such as organizational activity, and also included a number of geographic characteristics as well. And we estimated sibling fixed effects models with a number of different approaches. The main results I'll be showing to you today are which were estimated with hybrid correlated random effects models, which basically allow you to look at within sibling associations, which only exploit a variation within a sibling pair, and between sibling associations, which only exploit variation across sibling pairs. And then, but we also did a number of alternative sibling fixed effects specifications, such as conditional logistic regression, fixed effects models, ordered logit models, as well as linear fixed effects models. And those are included in the paper. And then secondary analyses examined individual diagnoses. So in terms of overall health, as you'd expect, the overall health is quite good. Majority are reporting excellent or very good health. Only about 7% report fair poor health, which is what you would probably expect with children. But a number of them do have mental health and substance use conditions that started in childhood, especially ADHD, which was about 9%, conduct disorder, which is around 7%, and depression, which was about 11%. These are the main results. And you can see that self-rated health had a significant within and between sibling association for both religious service attendance and team sports participation. So it suggests that both the association across siblings and the fixed effects estimate within siblings is significant, which is a more robust effect that nets out the effect of shared family, genetic, and neighborhood characteristics. And greater self-rated health leads to increased team sports participation and religious service attendance. Meanwhile, we didn't find any within sibling effect for volunteerism, despite there being a between sibling effect. So that suggests that some form of family, genetic, or maybe neighborhood confounding is explaining that association. And then we find very large negative effect of childhood mental health and substance use conditions on social isolation, and very similar estimate in between and within sibling effect, within sibling effects. And this is largely driven by depression, as well as substance disorder and ADHD, where we find quite large and similar within sibling effect. So important to remember some of the limitations where, there's some other measures of social capital, such as generalized trust or organizational memberships that would have been also interesting to examine. They weren't available. Sibling fixed effects results are usually a lot less precise because you're only using part of the sample, the sibling sample, and then only part of the variation. Um, and there was recall bias for some of the measures, but in sensitivity analyses, we only used wave one values and we find the same findings. So I don't think that's a big issue. Um, so, the main contributions are that there's rigorous assessment of multiple mental health diagnoses that are among the more, and these are the most prevalent and burdensome health conditions. There's very few studies on this topic, none using sibling fixed effects models, which are the gold standard within economics literature. Um, and this hasn't been studied previously in economics literature, despite there being a large interest in how childhood health shapes, education, labor market outcomes, and whatnot. So the results highlight another large deleterious effect of poor childhood health, especially poor childhood mental health, which I think strongly suggests it further bolsters the case for the urgent need for policymakers to address the mental health crisis among children, especially in Canada and the United States, as well as other countries. And even more recent evidence suggests that most children with mental health concerns are not getting evidence-based mental health-related interventions. So I think this results further bolsters that case. It also suggests there's probably additional returns not previously recognized to intervening to improve child health. Um, and it suggests, this poor childhood mental health may be contributing to the loneliness epidemic that we're observing right now. The third study focuses on the COVID-19 pandemic. And the questions were about what is the effect of lockdowns on people's interest to volunteer and how did the demand for volunteers change in response to different COVID-19 lockdowns. And we used volunteer post data from Canada's largest volunteer recruitment platform. And we examined for the first time how the demand for volunteers and the supply of volunteers changes in response to a pandemic. And we find large reductions in demand for volunteers, and we did see large short-term increases in interest to volunteer. They were primarily driven by COVID-19 related volunteering, but that interest didn't last, only lasted for a small number of months. We used volunteer post data. So these are basically posts on a website that nonprofits, including registered charities, volunteer-run organizations, public agencies, are posting in order to recruit volunteers for various positions. Data on postings were available from February 3rd to 2020 to January 4th, 2021. And they were downloaded from the online systems, collected every about 1 to 4 days, on average about every 1.3 days. Postings were included when they were active, so they were searchable on the website and accruing views. And in the end, we had about 1,700 volunteer position postings, about 250 days of data, about anywhere from 2 to 250 observations for any individual volunteer position, with an average of about 50. The average for volunteer position postings was 51 days. So we had about 88,000 post-day observations. The dependent variables were the supply of volunteers, which was the views and the time that were estimated between subsequent days, and which we used to calculate the daily rate. Current limitation is this largely reflects interest rather than, we don't have measures of recruitment or hours worked. But I think for cross website wide, I think there would be a strong correlation between overall level of interest and as well and applications and actual supply of volunteer hours. And then we looked at demand for volunteers, which was the total number of postings available on the website. We looked at we had data basically for the first year of COVID. So the first COVID case occurred in Toronto, Ontario in January 25th, 2020. We started collecting data February 3rd when there was no physical distancing restrictions. The first lockdown occurred March 11th. 2020, with very stringent gathering limits to only 5 people, closure of all non-essential businesses and city services, and there's a number of other restrictions. This was relaxed a bit in stage 2, starting June 24th. The gathering limits went to 10 people. There's reopening of some non-essential businesses and recreation and cultural spaces. And then stage 3 was the least restrictive period during this time period, when there was gathering limits set to 50 people, outdoors was 100 people. But it's still like tricky because, for example, that would be highly impeding on people's ability to get married, for example. And that was a big issue back then. And there was the lowest level of restrictions on business and city cultural services. Restrictions increased October 10th. And then there was a second lockdown November 23rd, where the restrictions were very similar to the first lockdown that started March 11th. I think for this study, there was some modeling, but I think the descriptives really tell the story. The first panel shows the daily number of active postings, so demand for volunteers. And you can see that there was a very large drop off in demand, almost about 60% decrease. About 50% decrease in demand. Meanwhile, there was a large shift to remote and COVID-19 related positions, which didn't exist before the first, or minimally existed before the first lockdown. So that you can see that the nature of volunteering changed quite dramatically. And there was a very large drop in, close to 60% drop in non-remote or non-COVID-19 related volunteering positions. The second panel shows the average rate of views, and you can see that during this first lockdown period, there was a dramatic increase in interest to volunteer for COVID-19 related positions, as well as a very large increase in interest in volunteering for remote positions. Overall, interest did increase during this period, but you can see it was relatively short-lived, and by the summer least restrictive period, all of these forms of volunteering were basically met a new low. And then the last panel shows the total rate across all volunteer positions. And you can see that during the first lockdown, there was a big increase in interest to volunteer, largely driven by COVID-19 and remote positions. And then by the summertime, interest largely returns to what it was pre-COVID. Try to better understand the COVID-19 related positions. We broke this down by further by types of positions. And as you would expect, based on natures of the laws that were passed, in terms of the gathering limits, as well as all forms of healthcare volunteering largely being shut down, there was a dramatic drop in hospital and long-term care related volunteering positions. There's also a large drop in event assistance positions. Initially, in terms of people's interest to volunteer, it was largely driven by poverty-related initiatives such as food assistance and relatedly driver positions where people were delivering food, for example. And to a lesser extent, it was also driven by mental health support-related initiatives. And you can see that remote positions, which basically didn't exist before the pandemic, were very low, are fundamentally very different than non-remote positions, with a much, much greater focus on marketing, communications, fundraising, and customer service related roles. Meanwhile, health-related or senior-related type visiting positions, which were heavily affected by the restrictions, largely disappeared. So it's important to remember the limitations that this is it is Canada's biggest platform, but it is only one city. We had only views, not recruitment hours or overall levels of recruitment, and we didn't have qualitative data to uh, further unpack these findings. But it does add to the crisis literature and volunteering, highlighting that, like some other studies, that the response to crises appear to be short-lived. And it may be in part because when the lockdowns were lifted in the summer, maybe community need is not as apparent, or maybe it was better addressed by government policies such as CERB and other income supports that were passed in Canada at that time. Um, and it highlights that these findings highlight that crises and the associated policy responses can fundamentally change the nature of volunteering in terms of the mix of positions, the types of positions in terms of whether they're remote or not, and which very likely has an important effect on social capital and the benefits people can derive from volunteering. I think along with some other findings from the COVID pandemic, early on in the pandemic, I think it strongly supported the need for more support for the nonprofit sector. And across these three studies, I think they provide fairly robust evidence that health and health-related policies can play a large role in influencing people's individual levels of social capital. I think they suggest that there's a greater need to take social capital into account in mental health-related interventions. It suggests that there needs to be greater focus on methodological approaches when it comes to studies on social capital and health, given a large number of studies in the past have used cross-sectional data and haven't accounted for simultaneity and reciprocal relationships. And there's a lot of future directions where this research could head. None of these findings, except for maybe the COVID findings, really shed light on mechanisms of the findings, which future studies could examine. I think there's a lot of work that could examine specific diagnoses and potentially maybe specific mental health symptoms. Studies could look at heterogeneity across different populations. I think there's more work that needs to be done to examine the longer term impacts of the pandemic. And I think more general improvement would be more inclusion of social capital and relationship type measures in clinical trials of mental health related interventions. With that, I'd like to highlight there's no project specific funding, but I was supported by a scholarship from SSHRC in Canada. Also acknowledge Ad Health, who provided the data for the child health survey. And with that, I'd like to open the floor to any questions and comments. Thank you very much for this opportunity to present these results to you.
Great. Thanks for the fascinating presentation, Michael. So we'll open the floor for questions. If you have any questions, feel free to post them in the chat. If you're not in a position to actually unmute yourself and read them out yourself, just let me know in the chat and I'll happily read them out on your behalf. Otherwise, when you're called upon, if you can unmute yourself and ask your question, then feel free to follow up with any follow-up questions as well. So any questions from the floor? I think I might start with the first one. As you know, I'm pretty interested in and fascinated by the different definitions of social capital and how we go about defining it. And the way you defined it is obviously quite a useful one as the social network-derived resources and clearly linked to the logic of capital because it's generated from prior investment. And I may have missed it, but can you describe a little more what you mean by resources and so that maybe the audience can understand that a little better? Because it's a term we see so often in the literature being thrown around, but it's not always clear what resources really means.
Resources are, in a way, I think there's different types of resources. So like the economic models, they tend to highlight that, the stock of social capital might provide different types of benefits, both market benefits, like it may help you find a job. It might, help you advance your career and get promoted and reach a higher level of income. And then non-market benefits, like things like which were the kind of more of the things that I kind of measured in these studies, which are things like social support, like different types of social support, like emotional, instrumental social support, um, as well as the number of close friends in the one study. The way it's written is close friends are people who are willing to provide you a favor, basically, or listen to. I think it was provide a favor, or support you and listen to you. I think when times are tough or something like that. But it's very clear that it's not just this is a, I guess, quote unquote friend. It's somebody who's a friend who will provide you some kind of support.
Yeah. And that's kind of central to what social capital is, isn't it? Yes, that potential to do something to provide some sort of a benefit. And if you just simply know them, but there's that potential doesn't exist, then it isn't exactly much of social capital. Because you pass them in the street, you know them, you might say hello, but the potential for those kinds of benefits you described to occur is pretty low.
Yeah, I think, I mean, in part because largely focusing on more of the economics literature, in that literature, there's a very heavy focus on individual social capital, much more so than the societal social capital. Just in part because I think most economic models, they tend to focus more on individual behaviors and decisions and investment decisions over time. Um, so those models, I think there's some examples, that apply to more societal phenomenon, but generally they focus more on individual behaviors.
Yeah, and I guess the like individuals is where it happens. Like we're not talking about the actions of society overall. We're talking about the actions of individuals, and the ways in which individuals are connected is central to that. And of course, there's the properties or the qualities of those relationships, but social capital doesn't exist in thin air. That's kind of I'm not sure if you agree and other economists agree, but social capital exists in people, and so to me it is completely logical and appropriate to look at the individual as the site of the social capital, and to therefore analyze and collect data on that basis, which clearly
Yeah,
you agree with.
yeah, I agree. I think
Yeah.
that it doesn't. The third study I think I did with COVID pandemic, I think that speaks a bit more to the societal aspects, especially because especially the demand for volunteers, because that's you know with that being so much lower than before, clearly there's certain segments of society that are no longer being served through volunteerism, for example, like the one graph that showed the difference between remote and non-remote positions, and how visiting seniors and visiting healthcare settings, like volunteering in hospitals, that's largely an in-person activity that didn't get transferred into the remote to be a remote activity, and those type of opportunities largely disappeared. So same thing with event assistance. So it highlighted that at least during the first year of COVID, there was basically no large scale events that needed volunteers. Maybe there was some online, but you don't need anywhere near as much volunteers, I think, to run an online event compared to like a large scale in person event with, you know, you know, potentially hundreds or thousands of participants.
Yeah. And I guess it's challenging to untangle the causal effects there, because the pandemic created a sense of perhaps urgency or a need in certain areas. Perhaps people had a perception that other people needed support and therefore they should go out and volunteer. Perhaps they had time and space in their own lives to do so because of the interruptions of the pandemic. And so it created a lot more effectively voluntary association, which then in turn created the conditions for the creation and formation of social relationships, which then in turn creates the potential for a lot more social action to occur. So untangling that causal mess is challenging, and a lot of it can be tangibly linked to social capital in the way in which you've defined it. But there's clearly some broader societal, historic, event-based factors that are playing into that are then basically impacting the nature of it.
Yeah. Related to that, I think one limitation of the data is that I don't think I mentioned this, but these are formal volunteer posts with largely formal volunteer-run organizations or nonprofits or hospitals and other government-related organizations that recruit volunteers. There is literature with respect to like crisis volunteering that focuses on spontaneous volunteering, I think more akin to what you're describing. And I think there was some discussion of this in the UK with, I think these, I forget what they were called, but like these kind of spontaneous small volunteer organizations that were like a lot less formal that were helping people early on during the pandemic. And it's hard with the data I had, I couldn't really examine that specifically in Canada, and maybe that occurred to some extent and is not reflected with this data.
Yeah, and there's also some literature that looks at the role of social security in general and the safety nets that perhaps are provided by the government in reducing the perception that people need to volunteer their time. You know, if they think the support programs already exist and are provided through governmental programs, then there's some evidence that suggests people don't feel like they need to volunteer. Whereas if society is hard and there's a lot of poverty and homelessness and the government isn't providing that support, then people feel like they need to volunteer their time for those who are in need. And so these are that kind of big picture societal influences on the nature of voluntary association. But I think the point that we're making here is that that's not necessarily what social capital is. It's more that the voluntary association creates the relationships and creates the ability for social support to occur. And that's basically what social capital is. So I'm hogging the floor. Anybody else have any questions that you'd like to pose? Feel free to post in the chat or unmute yourself if you'd like to ask your question. There's a comment on YouTube coming through. Of course, it's going to be difficult to have some live interaction for people who are on YouTube. But the comment is, please comment on social capital in BRICS, and that's capital BRICS. I assume it's an acronym. Like social capital in emerging economies. Some theoretical context will be interesting as well. Not certain that's relevant to your work, Michael, but if you have any comments about that.
Blair, I mean, I've done work on social capital in Canadian context, the American context, and I'm doing some research right now within the British context. I think you'd be a much better person to speak to that, Tristan, than me. I read a little bit about social capital in these other contexts, but it's not by any close to my area of expertise. So.
Yeah, sure. It doesn't sound like it's completely on topic, so I'll make a brief comment before moving on to other questions. I think that social capital ultimately is very similar, regardless of the cultural context, because everybody everywhere in the world, from whatever culture you're from, has relationships, engages in social support, engages in voluntary association in various forms. And so the construct itself isn't really any different. It's just that the actual institutional arrangements, the economic systems, all of that is different in different countries, but the way in which we can understand social capital, I think, is largely the same. I think brief comment about that.
There are some social capital surveys that have included 60, 70 plus countries and looked at trust and other forms of social participation and whatnot, and looked at these variables across many different countries, including some of the BRIC countries. And I don't think any of these studies have ever shown that any of these variables are completely not relevant to one of these countries, for example.
Yeah, perhaps just the way in which we measure these things maybe needs to be culturally sensitive. The actual question you ask about trust perhaps just needs to be sensitive to the way in which trust is understood within that particular culture. And even translations between languages as well can be an important factor. So I did have I'm not sure it's a question, but probably more of a comment. The study looking at, or I guess in general, your interest in looking at the way in which health impacts social capital is novel, and it's obviously revealed some really important results, particularly those that are reinforcing disadvantage. That if you have health problems already, then clearly has impacts on your ability to develop and form and make use of social capital, which then seems to reinforce that disadvantage further, particularly when we're talking about mental health problems. Um, and and so I think that this is really important to understand so that we can see how we might be able to do better than we currently are in facilitating social capital development opportunities for people who do have those health challenges. And so it's not
Yeah,
so
good.
much a question, but more a comment that I think the research that you're doing is really important, and I hope that it can inform some policy interventions that can change that for people who are suffering health problems.
Yeah, I agree, and I think like there's a lot of strong research that's shown that using a variety of different causal approaches that have shown that social capital is an important input into mental health. And with my findings showing that mental health has, this negative effect the other way, it probably suggests that there's some kind of, vicious spiral that can occur where, somebody's mental health, social capital deteriorates, and then their mental health deteriorates, and then that has this feedback mechanism that makes, it even worse. So I think it kind of suggests that maybe there's different ways you can improve things. Like you can focus on improving mental health, which will probably have some social capital returns, and then finding ways to improve people's who have mental health concerns. I mean, finding different types of interventions that could improve their social capital could also help stabilize their mental health as well. So I think it just adds complexity to the story and highlights that there's these different kind of feedback mechanisms most likely.
Yeah, certainly are. And I guess for anybody who's in mental health interventions, there's some important lessons here potentially to see how the two occurring simultaneously might help to break any negative feedback loops that do occur or that do exist. And I guess those negative feedback loops are going to be different depending on the mental health condition and even depending on the individual, the qualities of the individual. So different personalities, different family situations, different cultural contexts, probably going to play a very different role. But still, the existence of that negative feedback loop suggests that addressing both the social capital limitations as well as the mental health problems at the same time will help to break that negative feedback loop.
Yeah, I think definitely suggests the need for both. I think another thing I was thinking maybe like I'm not as familiar with this, but if you do, I did do a quick search looking at interventional studies and um, what health-related quality of life instruments they're using, and I think if most a lot of there's a lot more use of the EQ5D in these mental health related interventions than the SF6D, for example. And the SF, but I think that might be a mistake given like these findings, given that the EQ5D doesn't really have as much of a social component, and the SF6D has a much bigger social component. So I think, we might be missing out some of the health-related quality of life benefits in some of these trials when we're not incorporating these aspects. So I think there's a number of different ways, that in terms of including social capital instruments themselves, but also like maybe choosing better health-related quality of life instruments as well in terms of improving interventions going in the study of interventions going forward.
Yeah. And it sounds like it's the sort of thing that we really need mental health professionals to engage with and to find out more about. And I guess it sounds like there's also more research to be done as well to understand the relationship better and particularly how we might be able to intervene in these cases. Because if there is a negative feedback loop there, then it's not quite as easy as saying, "Hey, well, this person just needs to go and join the local sporting club," or like the kind of typical examples of how you might go about building individual social capital perhaps are either difficult or even not possible for those individuals. And so, how then do we break that feedback loop by having an intervention on the social capital side? So, lots of research to be done, and it sounds like you're continuing to do research that's going to support this space. So perhaps we'll have you back again in future for another webinar where we can hear more about the progress you've made on the research side. So any other questions from anyone who's here? Can't see anything else coming through on YouTube. Of course, it's a little bit more challenging with a little bit of a delay in the YouTube audience. Mike, did you have a question or comment?
No, I don't. Tristan, very interesting presentation, so I appreciate it.
Thank you, Mike.
Yeah, thanks, Michael. Let's wrap it up there. Thanks very much, Michael, on behalf of the association for giving this webinar. We greatly appreciate the time and effort you put into it. This will be a fantastic resource for people who are interested in investigating this in future.
Thank you very much, Tristan.
All right. Just stop the recording.